I'd like to thank Dr. Bhandari for giving me the opportunity, and I'm very happy to speak in front of Dr. Anshumala Kulkarni. So I'll take you through my journey of robotic surgery in obstetrics, tackling uncharted pregnancy complications. Can someone start it, please? Okay. So our first patient was a 31-year-old, fourth gravida. She was previous 2 cesareans, had 2 living issues, and presented at 14 weeks to our OPD. On examination, her BMI was 24, vitals were stable. On MRI, we realized that she had placenta accreta at her previous cesarean scar site. Since she wanted a termination of pregnancy, we decided to go ahead with a pre-operatively embolization, and this was our port placement. Once we targeted, we removed these dense adhesions between the omentum and the uterus. Our primary objective was to reach the lower uterine segment. So very gradually, we did an adhesiolysis so as to take a hysterectomy incision on the previous cesarean scar site. Now, as you can see, there were dense adhesions between the bladder and the uterus, and it was very important that we inadvertently don't injure the bladder. So, to reduce the blood loss, we had already embolized her the previous evening, and then we went ahead, instilled the vasopressin, again tried to push the bladder down because there was invasion into the hysterectomy site. Now, with that, we opened up the uterus in the lower uterine segment. And as you can see, the placenta was peeping out along with the gestational sac, and the fetus will subsequently come out. So the idea was that we have to minimize blood loss because placenta accreta spectrum is now increasing in women who are undergoing either 1 or previous 2 or 3 cesarean scars. So very gradually, we removed the placenta, and as you can see, blood loss has been minimized. We had the blood bank on board, and they were willing to give us blood at any point if the patient would have lost a little more than usual. Now you can see the hand coming out, and since it was a well-formed 14-week size fetus with, the placenta right there anteriorly. So we went in very, very slowly. The umbilical cord and the fetus was extracted. So you can see the head coming out. And the question now was how to remove this little baby. So we got in a bag, and in that we placed the fetus along with the umbilical cord and the placenta. So with very minimal blood loss, we managed to retrieve the fetus. Had we gone in for a laparotomy, we would have had a big scar, lots of blood spilling into the cavity. Here you can see it is more or less bloodless. So we irrigated the cavity, and the next step was to close the uterine scar. So we did a full thickness myometric closure with barbed sutures. It was done in a single layer, and since she had previous 2 cesareans, she was the wife of our own nursing officer in AIIMS Rishikesh. Our next challenge was to remove the baby. So with a 3 centimeters scar, we managed to retrieve the baby and put in a Surgicel there. So our operating time was 1 hour and around 20 minutes. We finished the case, and this is the second case that I'm going to present. So this was a primary 21 weeks who presented to the emergency department with pain abdomen. On examination, she had a pulse of 112. Her blood pressure was stable. Per abdomen, we could not make out the exact size of the uterus, There was tenderness, and an ultrasound revealed a fetus of 19 weeks size in the peritoneal cavity, no cardiac activity, with free fluid and internal echoes. There was a well-defined heteroechoic vascular solid cystic mass. We got an MRI done, and there was moderate hemoperitoneum with a single fetus in the abdominal cavity lying just above the placenta, and the fetus was in the transverse position with the head towards the maternal right flank. So again, we got the radiologists on board. We did an angiography and did a selective embolization. Now you can see as we went in with the robot, the fetus was lying transversely. The head was in the maternal right flank. You can see the placenta had extruded out. So we were suspecting a uterine rupture. Now the umbilical cord was disconnected from the maternal and fetal side. And very gradually, when we went in, we could see the placenta had been expelled out, and there was a ruptured rudimentary horn, which had been reported on MRI as well. Initially, when the patient had presented in the emergency, we thought it was a secondary abdominal pregnancy. Immediately, we had got the MRI done, and with our radiologist colleague, we did an embolization so as to minimize the blood loss. The patient was overnight stable, and we could take her up for a robotic procedure, because if you normally see in an emergency obstetric patient, a laparotomy is warranted. But here, it was just an out-of-the-box thinking of taking her up for a robotic procedure, because very few have ventured into the obstetric stream when it comes to utilizing the robot. So here you can see the normal uterus with the left ovary. There is a ruptured rudimentary horn on the right side of the screen, the ovary, and the tube. So we decided to remove this rudimentary horn using bipolar and hot shears. And along with the rudimentary horn, we even did a salpingectomy. However, we preserved the right ovary on that side because she was a young lady and we could not afford to compromise her. We are in reserve. The question was how to retrieve this 5-month-old baby. A colpotomy was done, and first we removed the rudimentary horn through the colpotomy incision, followed by the baby and the placenta. The colpotomy incision was closed with barbed sutures, and the histopathology was similar to what we had expected. So both these cases, they highlight an out-of-the-box thinking and innovative procedure, demonstrating the significant impact of robot-assisted surgery in managing complex obstetric cases. This approach not only enhances surgical precision and patient safety, but also paves the way for obstetric care in patients with an obstetric complication. Thank you.
I think very well managed these two conditions, obstetrics, and I think we can very well appreciate the extension of the use of the robot in obstetrics. Not many of the reports, and you can say the experience is there, but definitely in emergent situation, if you can manage it very precisely by controlling the, you can say, the blood loss, as well as taking up this kind of a procedure, definitely this brings in lot of, actually, you can say, the quality to the patient care. Thank you.
It's expanding horizons in obstetrics as well. And I think the message I want to give here is that you need a teamwork. So it was not just the obstetric team, that is the senior residents, our junior residents, as well as the nursing staff. Everybody was on alert. Our emergency OT was always alerted that we might need to convert this patient from a minimally invasive into an open laparotomy. And even the blood bank, the radiologist, everybody had supported in us in doing this case. So the first one, of course, has not been presented anywhere, has not been published, because what people felt was that if it is a placenta accreta spectrum, all you need is go ahead with a hysterectomy. So we can avoid a hysterectomy when it comes to placenta accreta spectrum with, of course, increta and percreta. by this minimally invasive approach if the patient comes to us early. And another thing I want to highlight is that she had taken mifepristone and misoprostol for an early abortion in this pregnancy itself, because with previous two cesarean and previous two children, she didn't want any further childbearing. So whenever a woman with previous cesarean does not abort, one has to keep placenta accreta spectrum in mind. Thank you, ma'am.
Very well presented, Anupama. Just one quick question.
Yes, ma'am.
Other than the fact that, of course, this is advantage to patient because you went ahead and did an open procedure, minimal access and less blood loss, anything surgically that you felt was an advantage because you chose to do this robotically rather than open? Anything in particular which you felt that the robot actually contributed and made it better as compared to open surgery?
I think ever since I started my robotic journey with you, of course, guiding me on my first cases, I always felt that just benign gynecology and malignancy were the two main indications. So I thought, why not venture out of these two and see whether we can do something in obstetrics as well. So I had done a scar ectopic pregnancy and even a patient with puerperal sepsis, in which we did a subtotal hysterectomy. And then these two cases, I think, were godsend.
Thank you.
Hello, everyone. My name is Toshiya Itoh from Japan, and it's an honor for me to be here, such a wonderful place. Okay, I have no COI. At our institution, when performing a total hysterectomy for early stage endometrial cancer or early stage cervical cancer, we perform extrafacial or modified radical hysterectomy by isolating and cutting the uterine artery medial to its intersection to the ureter. And inside the intersection of the uterine artery and the ureter, the veins are in close proximity and run in a variety of directions. So this makes the procedure difficult due to the risk of bleeding. So this technique is not in common. I will describe our technique in 5 steps using figure. Dissect the ureter to the point at which it crosses the uterine artery. At the intersection of the ureter and the uterine artery, release the medial fascia of the ureter. Mobilize the ureter as laterally as possible. Dissect the uterine artery from the surrounding tissue to increase its mobility. So the mobility of the uterine artery is increased. The space is created to cut the uterine artery inside the intersection. We can isolate the uterine artery and cut it in the space medial to its intersection. Then dissect the ureter to the required extent and cut the uterine veins at the parametrium, remove the uterus. The patient is 40-year-old woman with adenocarcinoma in situ of the cervix. And in the video of this case, we use Hinotori, which is the first surgical robot system made in Japan. Each port is arranged like the schema. And this is a surgical video of modified radical hysterectomy using Hinotori. Dissect the left retroperitoneum and divide the uteroovarian ligament. And we continue to dissect the left retroperitoneum. And we identify the left ureter in the left retroperitoneum. And dissect the bladder away from the cervix. And we use straight needle with thread to mobilize the bladder away from the cervix. After that, we continue to dissect the bladder away from the cervix. And we will proceed to cut the left uterine artery. dissect the ureter to the point at which it crosses the uterine artery. At the intersection of the ureter and the uterine artery, release the medial fascia of the ureter. Mobilize the ureter as laterally as possible. Dissect the uterine artery from surrounding tissue to increase its mobility. And this area has many small veins. We can isolate the uterine artery in the space medial to its intersection with the ureter. I hold the uterine artery and the ureter is there. And cut the uterine artery at this point. Then dissect the ureter to the required extent. Divide the left uterine veins at the parametrium in the visible state of ureter. It's very safe for ureter. And after division of the parametrium, colpotomy is performed. In robotic surgery with hinotori, the stability and multiple joints of robotic arms enables us safely perform this technique, which is very difficult in laparoscopic surgery. Here are the perioperative outcomes undergoing this technique for early-stage endometrial cancer. There are no complications, and the results between Da Vinci and hinotori are almost same. This technique does not require cutting the uterine artery at the main trunk of the urethral or the urethral branch of the uterine artery. Ureter is exposed to the area near the vesical uterine ligament. Extrafacial to modified radical hysterectomy can be performed. And in addition, this technique can be applied to highly obese patients, such as those BMI over 50 or cervical myoma, enabling us safe and curative surgery. In conclusion, in robotic surgery, by utilizing stability and multiple joints of robotic arms, the uterine artery processing method, which is difficult in laparoscopic surgery, can become a standard procedure. Thank you so much for your attention.
Thank you. Just two questions to you. I saw an illumination in the vagina transvaginally when you were doing the dissection for the bladder. So why do you do that and how do you do it? Secondly, you're using an advanced bipolar for dissection of adnexia. So is that a laparoscopic instrument, or does your robot have an advanced bipolar system?
Sorry, first question, we use trans illuminator. About? We like to use trans illuminator cup because it is very clear where I should cut the vagina. And in case of Da Vinci, we use firefly mode, and we can identify the colpotomy light with green light. It's very useful, and it is not available for hinotori, but I like the illuminator cup. And what is the next?
The next question is that for the adnexia, you used an advanced bipolar system, like a ligashot, which you use to cut the adnexia. Is that a part of your robotic instrumentation, or it's a laparoscopic thing you're using?
Yes. Actually, it is not equipped with vessels here with hinotori, so we use a laparoscopic vessel sealer through system.
Very good. Any comments, please? Yes.
Why did you envisage doing this? Because I think the 45 cases you presented are all endometrial cancer patients.
Yeah.
Okay. You are anyway opening the retroperitoneum there for lymph node dissection. most often the easiest place to clip or cut the uterine artery is at its origin from internal iliac. What was your thought process to think to go medial to the ureter? Why did you choose this technique?
Yeah, because these techniques help us quickly performed quickly and safely because the ureter is very clear during the dividing the parametrium, and originally we divide the uterine artery outside the intersection, and
That's the use
yeah,
that is done.
yeah,
I'm
yes,
just trying
yes.
to wrap my head around that. Why did you think that in doing in malignancies? So, listening to your five-step technique to any of the junior surgeons in gynecology that are sitting, I feel it could be a very, very good stepwise dissection and ligation of the uterine artery. Medial to ureter, especially in benign cases, especially in endometriosis, where there is a lot of fibrosis in that area, and we need to remain medial. We don't have to go very lateral because we are not doing lymph node dissection. So I think an excellent technique. Just wanted to understand what was the logic in your head,
I think
but an excellent technique to follow. Thank you so much.
Yeah,
I think in his
thank you.
last slide he explained that he wanted to preserve the ureteral artery coming from the uterine. So the incision was medial to where the branch of the ureteral artery was. I think that keeps the ureter safe and allows the vascularity to remain.
If I can comment. I think this is very much fit for the type 1 hysterectomy. That is
Type
just,
1,
yeah.
yeah.
So we are not doing this as that of the radical, that is type 3 hysterectomy, where Dr. Roma is mentioning about the ligating the uterines right at the origin, because we don't require to remove that much of the parametrium. So this technology can be used in type 1, and especially that can be of benefit in uterine malignancies, right? Or in very early, you can say, the B1 disease, where the lesion is very, very small. Most of the time, one B1, we like to go for type 2. So this technology or this technique should not be confused with type 2. As in type 2, we require to dissect the ureter.
Yes, yes.
And at the place where it is crossing the ureter, that is the place where we ligate the uterine arteries. So I think this should be taken as type 1. So most of the time, in benign or in malignant. So far as malignant, it is uterus confined disease, the disease which is not involving the cervix, where it can be used. This is what I could understand. Important point what I could see was the dissection, especially taking good care that the uterine is very parallel to that of the cervix. You have taken that tissue, and also to exclude any kind of the injury to the ureter. So I think the uretrovesical junction was very well pushed laterally. This is what you had dissected.
Yeah.
And making it, skeletonizing it, and then ligating it, that really ensures that yes, you're not going to injure the ureter. It was a wonderful presentation. Thank you.
Yeah, thank you so much.
First of all, I want to thank the Batikiti Foundation and also Dr. Bandari to let us present our experience on living donor uterus transplantation. So I'm going to explain you our experience on uterus transplantation, that it's a study, that it's the feasibility study of uterine transplantation from a living donor. And we got the permission in our hospital to do 5 cases. So here you can see the donor characteristics, less than 65 years old, the first or second degree relative, complete disease of progeny, and history of a full-term pregnancy, absence of associated pathology, and acceptance to participate. And then the recipient should have an absolute uterine factor, less than 40 years old, absence of associated pathology, and response to the IVF cycle with the good embryons, and the acceptance of participation. So the most important part, all it's important, but the donor surgery is really, they have to be really well done because we need good vessels for the good the good reperfusion of the uterus. And we started doing the surgery with laparoscopy, and then we moved to the robotics. And the first thing is the ureter dissection that we have seen already in the other presentation, that in this case we need to dissect very well the tunnel to avoid any injury on the ureter, and also to obtain a good stumps of artery and the vein. So the vein dissection, we should go for the deep uterus vein and go until the hypogastric vein to get a good stamp for further revascularization of the uterus. And also the artery dissection, the dissection that also we have seen in the other presentation, that we need to get a good stamp, and we go until the hypogastric artery. So like that, we can obtain a nice stamp for the revascularization and to avoid to clip the gluteus artery. Here you can see our first hysterectomy that they were done for myoma, and we look at the possibility to get these good stamps and the good reperfusion, that you can see the change of the color of the uterus there. After that, we moved to the real transplant. For the recipient surgery, we have to perform the hysterectomy on the recipient to get also the stem of the vagina, the wall vagina, to could make the anastomosis. And then we will use the external iliac artery and the external iliac vein to perform the anastomosis between our uterine and hypogastric vein that we had from the donor. It's important to keep the ovarian vein because in some cases it's not enough vein drainage. So we have also to take into account that. We had done 3 cases. The first was done in 2020. It was a sister that gave the uterus to her sister. In this case, we had a rejection, but was treated with corticosteroids. And then after he had a baby a year and a half later, and at the same time we performed the hysterectomy. The second case, it was a mother that gave the uterus to the daughter. All of them were Rokitansky syndrome, as you can see here. It has been done in 2022. Also, we got a rejection that was treated without any problems after that. She had a baby, and in that case, she wanted more babies, so now she is looking for the second one. And the last case that was done last September, we had a problem. We had arterial thrombosis that we tried to manage during a week, but finally we had to make the transplantectomy a week after. So the immunosuppressant treatment, you can see here that we start breast surgery with mecofenolate, and then we move, we add the thymoglobulin, tacrolimus, and mecofenolate, and when the lady gets pregnant, so we change the mycophenolate with azathioprine to avoid any problems on the baby. So here it's the first case and the baby that you can see here that did well, really, really well. And as a take-home message, the uterine transplantation is still in the infancy, but it's growing rapidly. It is still an experimental procedure, and it's a real solution for the absolute uterine factor, and there is needs of guidelines and criteria that acts as a standard. So thank you very much.
Thank you.
And sorry, this is all the team that worked on the project.
How do you dissect the uterine vein? And what length you keep it? And what are the precautions which you would like to suggest at the time when you are harvesting it?
Okay, so I didn't show the video because they said that it just was 5 minutes. So we start the surgery, open the peritoneum, and we go directly to the common iliac artery, and then we keep the external iliac artery, the internal iliac artery, and we move from them. So we make the dissection of the internal iliac artery to the uterine artery, and then over that we look for the vein, for the internal iliac vein, and we check for the deep uterine vein. So in some occasions we couldn't find the deep uterine vein correctly, and then it's a tiny dissection to look for a nice vein that it will be later on a good drainage for the uterus. So it's a difficult surgery. It takes between 9 and 10 hours, and we have to share with the gynecologists and also us, the urologists, because I'm urologist. And the most important part also is the tunnel, the ureteral tunnel, that you have to be careful not to make any injury on the uterus, the uterine, ureter, and also to avoid any injuries there in the vessel. I don't know if I...
Have vaginal agenesis, Maria?
Uh,
And was the vaginoplasty done one step earlier or during this same transplant?
So the rocket,
Because
so in these cases, I don't really exactly know if they had any adhesion of the vagina. I know that they had really tiny vagina, and also after the uterine transplantation, we had to dilatate the
Dilate.
vagina. Yes,
Okay.
but it was not so not a really problems on the vagina suturing or that.
Okay, so probably the vaginoplasty was done as a step earlier before
Yes.
the transplantation was planned. That's a good idea because already this is a long surgery. There's no point including the vaginoplasty also in the same
No,
setting.
no, we don't do the vaginoplasty.
Okay, thank you.
Yeah, just one quick question. I think in India also there's a transplant program that happens, and most commonly they're using the ovarian vein now, I think, because the length of the vein can be quite big and large, and you can get a good harvest from it. Second thing is, since it's a menopausal lady who's donating the uterus, so 60 plus, the uterus has generally atrophied, and blood vessel diameters are also very small. So, do you recommend actually doing prepping with hormone therapy for that uterus before you take it from the recipient? So, when you are menopausal, the uterus is atrophic, the vessel diameters have shrunken. So, you get a smaller diameter vein and artery. You're going to transplant it in somebody who's an active hormones there. So, do you treat the recipient with hormones before you take the graft from them?
No. The patient is treated by hormones to get the embryos and to.
Yes, I'm talking about the donor.
No,
For
no,
the donor.
no. The donors, they have been mothered, so they had a pregnancy before, and then.
But when you're
but
menopausal,
no.
everything atrophies.
Yeah.
So in a
No,
menopausal lady who's donating her uterus, do you prep it with
No.
that? You don't.
And I think that the problem it's not the length of the vessel that we got, it's the diameter. The diameter, because when we started on the first laparoscopic hysterectomy to check whether we had a nice stamp for the revascularization, we have seen that most of them, there are really tiny veins. So we didn't go far away because it was not for the donation, it was just for a regular hysterectomy, and we didn't want to do any injury to that gel. So, and the problem is the tiny diameter, not the length of the vein.